So the CDC has published a detailed checklist for Ebola preparedness. And while this is not law, it is certainly a standard and one that we want to meet. And so we've worked on what our organization is doing and how we're complying with each of the items in this checklist. And again, what they allow us to do is design our procedures to accommodate what works for us while still following the general principles and practices. And so there's a lot of guidance out there that is much more hospital specific and less specific to our role as fire department BLS first response. And so we've made adaptations that still meet the principles of this guidance, but fits in with what we're more accustomed to or lets us enhance capabilities that we will most likely need for the future. One of the items on the checklist involves that all personnel need to understand some basis for this disease. And so Ebola virus is rare but quite deadly at this point, and early recognition is what the critical piece is for infection control. The key item, as we've mentioned previous training and continue to reemphasize, is that it's a history of travel to an area where there's an outbreak or contact with somebody who has. The symptoms appear anywhere from 2 days to 3 weeks after exposure. The average is somewhere in a week to 10 days. That's when symptoms appear. But the important thing is that patients without signs and symptoms are not contagious. The key sign or symptom, however you want to see it, is a fever. And if they are afebrile, they do not have a fever, they're not contagious. That is true, that is fact, that is evidence-based, and that gives us a very important screening tool. Now, all of us need to be aware of the various signs and symptoms, and fever is the top of the list. For a while, there was a specific level of a fever. There was 99 something for a while and 100.4 for a while, and now it's fever. Whether that is measured or subjective, the patient says, I feel like I have a fever, I have chills. These fevers tend to come on suddenly, but that's of course not specific to Ebola, but it may be helpful for you to realize that. Many times things that go along with a fever will also show up in these patients. And again, there's a continuum here. It's not like these patients get suddenly deathly ill. They suddenly develop a fever associated with headache, muscle pain, aches, weakness. There may be some diarrhea, nausea, vomiting, some abdominal pain, but that tends to be several days into the event. Now, no one's going to be able to predict when they're going to call us, but this is a continuum where the patient gets progressively sicker and sicker over a week to 10 days to 2 weeks, and some of their illness can be incredibly dramatic. Unexplained hemorrhage, explosive bloody diarrhea, explosive projectile vomiting. They may have associated symptoms like chest pain, short of breath, headache, confusion, and this is where it can be kind of non-specific in terms of why they call for help. So Joint Communications will screen based on a very detailed and well-vetted process, but it's quite possible that a patient will call and talk about symptoms that don't hit the joints trigger, and so that's why we're going to continue to screen all of our patients. Again, the symptoms become increasingly worse, may include some liver disease. These patients eventually more or less bleed out, and so they may have shock or multiple organ failure. In the end, these patients are incredibly complex and very, very sick. Probably it's likely that we will see them in the more early stages where they either do or do not suspect that they have Ebola, and that's where our screening comes in. Another key point we wanted to talk about was, and certainly the risk is extremely low unless you have direct, unprotected contact with body substances. So we're all about PPE and protected contact, and that's one key point here. The second one is this idea of sweat as a body substance that can transmit infectious disease. And in all of the training that we've done in the past, both in their initial EMT or initial paramedic class or EMR or whatever we've done, any of our continuing ed. We haven't really talked about sweat as a body substance. So we ask our experts about this, and the answer is that the sweat is specific to these Ebola patients, more commonly in the late stages. But what happens with Ebola is that they have these microscopic hemorrhages. The virus attacks the lining of blood vessels, creating a small amount of bleeding, and that bleeding can leak through to the skin. And so while the sweat itself is not particularly full of blood with virus in it, this microscopic leakage tends to look like and be encountered like sweat. So again, body substance isolation. None of our body substances touch them. None of theirs touch us. And in this case, in the very, very sick patient, the sweat is added into that. Just to be complete, working down the checklist from the CDC, there's this interim guidance that we've already put in place. A PSAP is a public safety answering point. So in our case, the Joint Communications 911 Center, and this is being handled and executed at a high level. And you may already have seen this show up in some of, if you see the notes, the full notes from a call in iStatus, you may have seen the EID tool terminated, meaning that the operator was working down that list of questions and got to a no answer that kicked them out of the questioning, and particularly that's the travel question. EMS staff should immediately check for symptoms and risk factors. We're doing that on all of our patients. Early notification of the hospitals to help them have time to get their process in order. CDC guidance for EMS, again, same stuff we've been talking about, but we needed to package it up and reiterate it so that there is continued focused training on this. And they're talking about screening from at least 3 feet away from the patient. We like to use 6 feet. And the 6-foot action circle is now the centerpiece of our infectious prevention or safety program. The 6-foot action circle. And then they talk about in general things for EMS crews and how they can work around. A lot of the checklist guidance is based more on transport services, so we've included what's appropriate for us in a first response role. If diagnosis of Ebola is being considered, so anytime we suspect, then standard contact and droplet precautions need to be included. Now, EMS training for November focuses in large part on the PPE. The overarching topic is scene safety, but PPE is first and foremost in our discussions there. And so we'll talk about standard contact and droplet, but really here's what it turns out to be. If you have any consideration that Ebola is involved, or until you can rule it out, then the only prudent and appropriate thing is to use precautions for standard contact and droplet, which means gloves, sleeves, pants, N95 mask, and goggles. The very same thing that we said in our rapidly deployed stuff in late October. It's the very same thing. And so the PPE is pretty well addressed to this point. What we are looking at more is this contact and cover scheme that we've used for many years. And the contact person will need to have immediate access to maximum PPE, gloves, mask, goggles, sleeves, pants, the whole bit. And that contact person can assess and manage that patient while the cover person remains disengaged but immediately ready to engage. In this case, I put this part on the guidance about EMS agencies and drivers, because that's one of our roles with the fire district, is that we will become the dedicated driver. And that person may not need to wear the PPE because the patient compartment will be isolated, but they'll have that full PPE with them. So they'll still be in level C, C minus we're calling it. So level C suit with the respiratory part of that ensemble ready to immediately don and integrate as best they can, so that they can operate in a more of a RIT role than anything else. Speaking of RIT, what happens if you're caring for a patient, you're appropriately wearing PPE, you're inside the action circle, and they suddenly vomit and you're in contact with it, or there's some other catastrophic thing that goes on where your PPE is covered with their body substances. What should you do? As much as possible and as soon as possible, disengage and wash the area, get the gross contaminant off, and then we'll work through the exposure assessment. Just because you have material on you means you're contaminated, but it does not mean an exposure has actually occurred. And then again, that's where that RIT person, that's where the cover person or additional people in a RIT mode can rapidly don the appropriate PPE or already have it on, which just makes sense, and be able to immediately engage and replace that person who was contaminated. And then repeatedly train. And so this will not be the only thing that we train on in coming months, but we will integrate into our training processes, both in the initial and in the Con Ed. We'll integrate this in repeatedly to emphasize this guidance.